I'm very pleased to welcome Professor Richard Sullivan to Sketch Notes. He is Director of the Institute of Cancer Policy and Co-Director of the Conflict and Health Research Group. He's also been involved, I know, Richard, that you are now involved with the World Health Organization, and I'd like you to tell us a little bit about that and what you're doing and what your concerns are. So would you like to talk about your role there and your involvement and what's really happening with the Ukraine?
Yes, of course, Lucy, and delighted to be with you. So I'm a non-communicable diseases advisor to the World Health Organization. And within the division of non-communicable diseases, obviously cancer and palliative care is a major area that we look after, and we look after it from a global level. I have a particular interest and speciality in cancer and palliative care for populations in conflict. And most of the last few years, obviously, this has been dealing with refugees in the Middle East, particularly those displaced to Lebanon, Jordan, and Turkey from the Syrian conflict. But of course, what's happened right on our borders very recently is the Russian invasion of the Ukraine. And that's caused enormous impact on the healthcare system in the Ukraine, both direct in terms of the attacks against healthcare facilities and also indirect because of the damage to the infrastructure, water supplies, etc. And as part of this, WHO, the United Nations, and various organizations within the United Nations and other organizations have been mobilizing to provide both support to the internal healthcare system that remains within the Ukraine, but also to deal with this huge influx of refugees and the care needs there. And I'm specifically involved with the task force that's being coordinated and led by the WHO on dealing with cancer and palliative care, both within Ukraine and trying to keep some systems and services going, and also in planning for refugees as they move into neighbouring countries.
So do you have people on the ground out there, and how does that work? How are you working with the agencies there to firstly keep services going in Ukraine, and are you worried about that?
The first thing to say is maybe to recognise the incredible dedication, hard work, and what it must be terrifying conditions for our Ukrainian oncology colleagues, who, particularly those in Kharkiv and Mariupol, under direct attack, and of course, every day the Russian forces move closer to Kiev as well, where major cancer centres are directed. They've been able to keep cancer services going, which has been absolutely remarkable, including critical childhood cancer services. So they're really feeling the brunt of it at the moment. We have logistic teams now in most of the countries. There's a major logistic hub in Poland. Most of the refugees coming out of Ukraine, and we're nearly hitting a million mark now, according to the UNHCR, are moving into Poland, but also sizable numbers moving into Romania, Hungary, and across to Moldova. In each of those countries, there are WHO representatives and key people, but we also have a very unique and what I would call distributed group of individuals in these countries who are obviously in major cancer centres. So these are cancer centre directors and other oncologists who are also providing a huge amount of support and technical advice. So we're talking about a collaboration here that's extremely wide with many different partners.
So how are you able to reach patients on the ground outside hospitals? How is that actually happening? And also, do you know the scale of the problem, the numbers?
Yeah. So firstly, within Ukraine, Ukraine is a fully transitioned country. It has very high cancer burden. We're talking anywhere between 2,500 to about 3,500 new diagnoses per month. This is what Ukraine was having before the war started. So first of all, we've got individuals who are now still within hospitals and still being treated, but many cancer patients now, of course, can no longer get access to cancer centres because they're trapped in their basements, they're trapped at home. It's far too difficult to move around. There have been evacuations already of a lot of patients, particularly childhood cancer patients now who are being moved out of the country. Other cancer patients are being moved further west to where cancer centres are still relatively safe and operating. The information coming out of Ukraine, of course, is very difficult and very sketchy, and it very much depends on where you are at the moment. Obviously, within Kharkiv and Mariupol, where the massive fighting is undergoing, there's almost no information, and we're making the assumption there is no cancer care available in any shape or form. The other difficulty, of course, is moving supplies, much needed essential cancer medicine, supplies to carry out surgery into Ukraine as well. And that's becoming increasingly difficult every day, to the point where, certainly over the next week, it may be almost impossible to move those supplies in. And finally, for radiotherapy, we know many of the radiotherapy centres now have been unable to continue because of interruption to electricity supplies and also just access of healthcare professionals in there. So the situation is really, I think, quite desperate within Ukraine, and speaks to the need for an immediate ceasefire, because this is the only thing that's going to protect those centres within the country itself. But at the moment, the negotiations are to try and get these essential medicines and supplies in to provide some semblance of care to those individuals who are in hospital at the moment with their cancers.
So when you say diagnosis, 3,500 new diagnoses every month. Can you translate that to sheer numbers of patients that are in Ukraine with cancer? Are we talking about what are we talking?
We don't actually know what the numbers of patients. So there's three groups of patients, rather. There are patients now who are having new symptoms of cancer. That's a massive problem, because they have no access to having those cancers diagnosed and treated as it stands. There are those patients who are undergoing active treatment. So they're taking chemotherapy, they're supposed to be receiving radiotherapy, they've perhaps been diagnosed already and were waiting to have their surgery. Those group as well have been massively interrupted. There are only a few centres still able to actually provide those sorts of services. And then there's another group, of course, who are in hospital as we speak now. And these are individuals who have already had their surgery or are receiving chemotherapy and are really quite unwell. For instance, a lot of blood cancer patients, childhood cancer patients, they're all inpatients. We don't actually know what the numbers are, nor exactly where these patients are, because you can imagine it's a very dynamic, kinetic situation. So as hospitals suffer outages of electricity, as the security becomes worse, patients, of course, are being rapidly moved around from hospital to hospital. So it's a very complex picture, but we know those sort of three groups of patients exist. For those who've simply got symptoms at the moment, the situation for those individuals is probably very bleak, because they will almost certainly now present with advanced cancers because of the delay in getting any form of treatment until there's either a ceasefire within Ukraine or because they become refugees and move into neighbouring countries.
So your intelligence out there on the ground, is it amongst other oncologists, or how are you receiving any information?
Yeah. So the outstanding sort of leadership in the Ministry of Health in Kiev, which is, been remarkable in their ability to continue functioning, the cancer lead there, and also amongst oncologists as well, who are connected both directly and indirectly. As you can imagine, many oncologists have friends and colleagues in other countries. They're WhatsApping them, talking to them all the time. And this is what we get. We get this kind of, essentially, this human intelligence of what's happening on the ground, which is the reason why we know it's so confusing and it's so chaotic and it's so difficult for the individuals in there, for both the patients and the oncologist.
So what can sort of European leaders, can this government and other European governments do any more to help you in your work and to help with this problem?
Well, firstly, to say, the war has to stop. The attacks have to stop. This is a violation of international humanitarian law, whether it's against cancer patients or others, to attack hospitals. And it's been particularly, I think, brutal and heartbreaking to see the attacks against Children's Hospital and children's cancer hospitals. The second thing to say is that, of course, we're seeing huge numbers of refugees now moving across the border areas. Poland is taking the vast majority, and we know this from UNHCR figures, but also, as I said before, Moldova, Romania, Hungary. Now, the issue for there is, obviously, one of the things is triaging those patients, to find people who are coming across the border who have already been diagnosed with cancer. So that's the first group, is finding those individuals and making sure they have a continuation of care in one of the cancer centres in those neighbouring countries. That's critical, and that's something that...
How do we help with that? What can we do?
Firstly, I think this is a discussion between WHO, the UNHCR, which is the lead agency for refugees, in order to be able to triage them. The other issue, of course, is capacity in these countries' cancer centres to handle all these new patients coming in, whether it's the need for radiotherapy, whether they need surgery, whether they need systemic therapy, chemotherapy. At the moment, the numbers have been manageable because it's been relatively ad hoc as patients have presented themselves to these cancer centres. But as the numbers will inevitably increase, it's going to be more and more important to be coordinated, firstly. So this requires solidarity and coordination. But secondly, it's very important that these countries and cancer centres are not left to hang out to dry in terms of the funding. You have to find the money to pay for these patients. And this is where it's absolutely essential that the EU comes together, particularly with the high-income EU members, and I'm including still in this the United Kingdom, to actually provide the solidarity and the funding these countries are going to need to provide the care to the Ukrainian refugees. Now, cancer mission is one of the top things for the EU. It's hung its hat on delivering an outstanding cancer service over the last 10 years. So this is a real test for that sort of solidarity. It's a solidarity for technical support for people to help, and it's a solidarity aspect here for financial support.
What are your kind of worst fears, really? Do you fear that people will not be able to get the treatment that they need, and that, there will be cancer deaths, unnecessary cancer deaths?
There will now inevitably be a lot of unnecessary cancer deaths.
Including children?
Including children within the Ukraine, because their treatment has been curtailed, or they've been injured and killed because of the bombardments of the hospital. We know that any form of delay in diagnosis or delay in treatment leads to avoidable mortality. And what we're going to be seeing is month on month, as if the conflict continues to drag on, is more and more delays for those individuals trapped within the Ukraine who are unable to get out. And for those individuals, the picture is incredibly bleak. The issue, I think, for the refugees is, and this is where it's been, I think, extremely impressive, the speed in which the World Health Organization has moved with the cancer coordination, is to ensure that those individuals who have had their treatments interrupted have their treatment continued as fast as possible, because that will reduce the avoidable suffering and also the avoidable mortality. The other big problem, I think, is going to be, if the conflict drags on and on and on, the refugees may be in Poland and Hungary and Romania and other countries in Europe, potentially for months or even years, depending on what happens. And in which case, people are going to start getting symptoms and be diagnosed newly, de novo, within these countries. And so there's going to have to be a whole new system set up to be able to care for people who become newly diagnosed because they develop cancer whilst they're refugees within Romania, Hungary, Poland, Germany, wherever they end up. So that's going to be an important medium-term strategy to look at. But right now, this is all about the emergency situation, identifying those cancer patients who are on active treatment coming across the board, and doing whatever we can to support patients and oncologists within Ukraine.
Have you ever seen anything like this before in your work in conflict? Has this been, is there some kind of pattern or some kind of blueprint?
Sadly, this has happened before. I mentioned right at the beginning about the Middle East. Syria, again, was a fully transitioned society, very high levels of cancer, aged population. So when the conflicts broke out there, we saw enormous numbers of cancer patients moving across the borders into Lebanon, Jordan, and Turkey. And what it exposed, I think, was two things. One is that we never really think in humanitarian care very much about non-communicable diseases. We tend to still focus on reproductive medicine, women's health, infectious diseases, and really non-communicable diseases have come quite late to the party. And a lot of the systems were really unprepared to deal with the impact of looking after cancer patients. By far, the best system was Turkey, because it had already had universal health coverage. It had excellent leadership. And I would also argue, I thought Jordan did extremely well as well in absorbing cancer patients. But it showed up just what a huge burden it is in terms of finding the clinical capacity to treat cancer patients, but also finding the financial capacity, because treatment, even basic treatment of cancer patients, is not cheap in comparison to, say, treating an infectious disease or dealing with other areas. And I think that really highlighted things. I'm not sure the international community learned very well from those experiences. I think it's where it has helped is the speed in which they've moved this time. And there's no doubt WHO and UN are moving very quickly this time in comparison. But I think for most of us in Europe, this will be one of the biggest things we'll see in terms of refugees and cancer and palliative care, certainly in our lifetime. And I hope we never see it again.
So the biggest sort of problem and displacement of people, you mean? The biggest problem, yeah.
Exactly, in terms of the cancer care, and also in terms of actually delivering that cancer care for the neighbouring countries and coming up with a coordinated plan. And in that sense, this is, I think, a real test for European solidarity. We've talked an awful lot about cancer as being a major thematic area for European health. And this is going to be a major stressor on these countries which are receiving refugees, and they need all the help they can get.
You mentioned hospitals that have been targeted, and I mean, do you know what the scale of that is and where they are?
No, we know most of them, of course, are in the east, in Mariupol, Kharkiv, and places like that, where, of course, there's been indiscriminate artillery and rocket bombardment, grad rocket bombardment by the Russians. So they've clearly been completely ignoring. I mean, these hospitals, their locations are well known. They're all geolocated. This is a well-known process of avoiding targeting hospitals, but that's not what's gone on. So, and also, I think it's worth making the point here, even if hospitals are not indirectly targeted, targeting the surrounding area will destroy water and it will destroy electricity infrastructure to those hospitals. And many of them do not have standalone generators. So you can imagine trying to run a hospital with intermittent electric supply or where the water is cut off is also equally disastrous.
Yeah, but we don't know how many hospitals are affected. But
no,
we know
not at the moment. But we know there's been a lot of sporadic reporting of this coming out.
So in your sort of daily work on this, and I know you do a number of things, what's your role and what are you doing? How are you trying to help the situation?
Well, two things. First of all, we sort of provide technical support and sort of cancer intelligence for the World Health Organization, because as a lead organization, they reach out to partners like ourselves and others, and they bring in that sort of expertise. So the expertise that we've had, particularly from the learnings we had in the Middle East, so the Research for Health in Conflict program, have been very useful. And secondly, what we'd also do is provide analysts as well to look into certain areas in terms of looking at particular data, analysing flows, what sort of cancers we should be expecting, and trying to match up the kind of burden with capacity and look more broadly then in how new pathways could possibly be developed to distribute the cancer patients across Europe. But as I said, this is all work in progress at the moment. It's been fantastic to see a lot of partners coming together very quickly. We're really in contact daily at the moment. And this is, a very rapidly evolving situation.
Yeah.
I think the crucial thing is, first of all, getting this planning done very quickly now. Mm-hmm. And number two is finding a way of stopping the war, because the longer this goes on, the worse things are for cancer and palliative care, and the worse things are for the health of populations in Ukraine.
Is there any message that you might have to this government that could perhaps help?
Yeah, I think firstly, we are going to receive, obviously, Ukrainian refugees in this country, and that's absolutely right. And what we really need to be ensuring is that we have a very sensitive and welcome approach in terms of cancer and palliative care. There will be patients coming in, no doubt individuals who've already been diagnosed, and they need to be properly looked after in our, we've got some fantastic hospitals, and wherever they're actually housed, those centres are immediately on top of their treatment. And also providing the services to ensure that anybody develops any symptoms, that they know how to access the UK system. It's going to be very bewildering. It's completely new. There may be major language barriers. And so I think we really need to step up the mark. The other thing is to do is obviously the advocacy that the UK can do still, even at European level, for ensuring that there is funding for those countries which will shoulder the majority of the burden of cancer care. And that's where we could also then support through financing. And there may well be, specific support that's needed for technical assistance in terms of education and training, even deploying some of our clinical staff to these areas. And we may see in the medium term there is a need for clinical nurse specialists, doctors to deploy, particularly if they have language skills. When many Ukrainians living in the UK, many healthcare professionals who are no doubt Ukrainian. And that will be, again, an important part that the UK can practically play as well. But I think it needs to be actively engaged in this, and I hope it really will be.
Mm. I mean, I don't mean to push you on this because obviously you don't know, but would you say we've got tens of thousands of people potentially who will be displaced into those countries?
As I said, the data at the moment is extraordinary. I mean, I looked today on UNHCR, and it's, I think Poland's looking at 852,000 already. We're looking at nearly 36,000 people into Hungary. And you don't need to be a rocket science to work out that with the instance of cancer, there are going to be quite a lot of cancer patients coming through. And what we're doing at the moment is doing those assessments to understand what are the sort of rough numbers we can be expecting to come through. Now, obviously, the first tranche of refugees were relatively young. They were young women and children. But we're now, of course, seeing that age demography change. And the other big issue, of course, is at some point there may be a mass evacuation of hospitals across borders, in which case we're talking about dealing with a large numbers of cancer patients, which then have to be housed within hospitals around neighbouring countries and around Europe. And that's something that, of course, has to be planned for.
Do you think, are there any barriers with refugees and their access to cancer care in this country and elsewhere?
Yeah, I'm going to be blunt. I think generally no one's really covered themselves up until this moment here. No one's really covered themselves in glory in looking after refugees per se. Everything from negative messaging to, particularly in the NHS, we had a situation not that long ago of a really quite strong what we call a hostile environment, which was made it very, very challenging to look after refugees. The great thing about the NHS is most doctors completely ignored a lot of the orders. And just carried on treating refugees.
Tell me more about that. What do you mean a hostile environment?
Well, what we meant was, basically this was going back a few years now. Hospitals were basically ordered to report individuals that were refugees that didn't have, formal asylum status, with the obvious, intention of actually using hospitals as a way of tracking these individuals down. Now, of course, this was something where most of us found completely outrageous. As somebody is sick, one of the primary tenets of the NHS is we don't ask, are you wealthy, are you poor, where do you come from, do you have a job, don't you have a job, are you an asylum seeker or not? We care for whoever comes through our doors in the National Health Service. And that's been a point of pride and principle since it was formed. So this was kind of, the orders were basically rejected roundly by all the oncologists I know. And we continued to treat anyone who came through the door. The issue really is that refugees face a lot of barriers to accessing care, even if the care is available. It's hard to get referred into a system. There are language barriers. There are issues, social and cultural issues. And each refugee, depending on where he or she comes from in the world, has a very different set of intrinsic barriers. Even if you can provide, as we do in the NHS, free care, it's amazing. I've been always amazed how many people want to then pay you because they assume they have to pay. So there's even misunderstanding of the care that's available in the NHS. So refugees are an extremely vulnerable population and require a dedicated view and a dedicated approach. Obviously, with Ukraine, this is going to be a different group of individuals. Again, we're lucky that we have a lot of Ukrainians in the UK anyway, and quite a dispersed diaspora. So this will help engage and integrate. But I think we also need to be very mindful about the sort of cancer burden we're likely to see and make sure that we have appropriate systems of care for them.
For the NHS, obviously, we have that as our principle, but there are other neighbouring countries which don't have systems like that. Is that also a concern?
Yeah, I think it's a major concern for us that, this is going to be a financial barrier for Ukrainian refugees to access cancer care in some countries. And we need to put in place a system that ensures they can get free access to care. Now, that's either through a direct social insurance model that can be applied to the individuals themselves, or it's about ensuring that those individuals are paid for on a per capita basis at whatever centre they end up being treated at. But one way or the other, it's really, really important. What we can't do is be going through this situation we've had before with the UNHCR, the Exceptional Care Committee, where patients have to be referred for them, reviewed, and this all takes time and, of course, massively delays the diagnosis and the treatment of cancer patients, which, of course, as we well know, is lethal. So a form of per capita or direct payment for treatment needs to be sorted out. We're not talking about countries which have enormous reserves of wealth to absorb lots of additional patients. So it's absolutely essential for Europe to show some solidarity here and fund this properly.
I mean, are you concerned that there won't be the capacity in Poland and Romania to absorb all these patients because they just don't have it? I mean, I don't know what we've got in the UK.
I think there is a major worry at the moment that cancer capacity could run out very, very quickly as the numbers coming across the borders increase. We're already hearing in other areas that capacity has been reached and exceeded. There are only so many hours in the day that radiotherapy machines can work. There's so many surgeons and medical oncologists. And of course, don't forget, remember, all these countries are still treating their own patients as well and recovering from the impact of COVID pandemic. So this is a really, really serious situation. Right now, of course, the ad hoc patients coming in can be managed. But if this trickle turns into a flood, we're going to be in a very different world very quickly. And it's going to be really important to be able to triage patients to other centres in other countries in order to distribute the workload where capacity exists.
Yeah. And can you just tell me a little bit about the other partners that you work with and what their roles are and what they do?
So the World Health Organization is coordinating partners from all over Europe and over the world. So you can imagine there are some very, very strong links between the USA and Poland, for example. So the American Society of Clinical Oncology is one of the sort of leading partners for the Polish Cancer Society over many years. They're part of this consortium. The European Cancer Organization, which is the big umbrella organization for the European Society of Medical Oncology, the surgeons, the European nurse organizations, etc., are also part of this. And then we have a number of patient advocacy organizations like the European Cancer Leagues, the Union for International Cancer Control, and others. The importance about the advocacy groups is twofold. One is to ensure very positive messaging about cancer care and healthcare for refugees. And number two, to act as political advocates at the highest level to ensure that the funding flows to these countries and these refugees to ensure the continuation of their cancer care. So it's a very wide group of individuals. And I would say first and foremost within this, of course, is the host countries themselves. So the cancer leads from the Ministry of Health, the cancer centre directors and the oncologists who will obviously be at the front line of receiving and treating those cancer patients. So it's a wide consortium because that's what's needed from both a political, advocacy and also practical treatment perspective.
Brilliant. And I suppose just lastly, you mentioned that many countries, including our own, are trying to catch up, or if you can catch up with cancer. As you said to me before, you might need a time machine or do need a time machine, but people could argue, well, we're overloaded here and we can't get treatment to even people in the UK. How on earth are we going to possibly manage refugees?
Yeah, I think this is one of the most critical issues here is how refugees are treated within already overburdened systems. But I think this is what it's going to speak to is it's finally going to shine a light on the fact that a lot of our systems are quite fragmented. We haven't been efficient in sorting out our pathways. There is capacity that can be carved out here. And I think sometimes these external stresses are important because they force us to address some of the uncomfortable truths and issues that we have in our own systems about inefficiencies, performances, fragmented pathways that are there. It also focuses, I think, the mind of the politicians very keenly on the fact that you need to support additional human resources. You need to support additional radiotherapy machines, additional nuclear medicine capacity, etc. And so what it can do is actually act as a catalyst for actually bringing forward political change and action and funding for national health services. So in that sense, it can be actually a really strong force for good. And I think, I've never accepted the argument that it's a trade-off, in order for us to treat our refugees, our own domestic populations must suffer. That's just not the case. All ships can float upwards.
I'd like to say thank you so much, Richard, for being on Sketch Notes and these important discussions. And I hope maybe we can follow up in a future time and look at the situation there in the Ukraine later on. But thank you for joining us today.
Thank you very much, Lucy, and thank you very much for shining a light on this incredibly major issue for Ukraine.